families that have a loved one or perhaps a friend dealing with Alzheimer's disease or perhaps a dementia diagnosis. So I do believe you'll get some great information today. And others of you are professionals that I know in the industry. And one of our greatest goals that is shared is to continue to be a resource for the community and for families. So I think we'll all walk away with a few more tools in our toolbox today.
Thank you for coming, and we are really excited and feel really thankful to have such an esteemed speaker with us today. And although she likes to downplay, you know, all the glitz and glamour, I'm going to just give you a little bit about Dr. Coleman. She actually is a physician who specializes in gerontology and has been on the advisory board, by the board of directors for the Alzheimer's Association for 8 years. And she's currently on the advisory council for health and human services. And so we are very glad to have her not only here today, but she's making the world tour at all 6 of our communities. So this is the second, we're just getting started. So without further ado, please welcome Dr. Laurel Coleman.
Hi everybody, it's nice to meet you this morning. I am incredibly casual, okay? So I realize that for many of you, you know, your visits or interactions with physicians are in 10-minute slots and you're hurrying to ask your questions. This is different. I love to answer questions and we have a lot of time, and I want this more like a conversation than, I mean, obviously it can't be exactly like a conversation. It's going to be a little one-sided. Or a little more on my side, but I want you to feel like there's interaction. And I'll try to answer questions during the talk or at the end. That's fine too. If I don't get to what you want me to get to, then we'll do that. Let me say to start just a little bit about what I do. So I was raised in Sacramento and went to medical school here in the Bay Area and fellowship in Chapel Hill, North Carolina. And then we moved to Maine. So I'm actually from Maine, and people always say when I'm in Maine, they say, "You came from California? How did that happen?" And it is a lot different than California and Maine. As I drove down from San Rafael this morning and I asked the people I was staying with, some friends, I said, "Okay, how early do I have to leave to cross the Golden Gate Bridge in order to be here?" You know, I realized I don't have to do that in Maine very often unless there's a big snowstorm and I have to plan ahead for that. But it is great to be back. What I do on a daily basis is a combination of things. I take care of people. I do some primary care and some consulting work at a geriatrics clinic, where another physician might refer someone and say, "Hey, help me with this," or "What do you think about falling, frailty, memory problems?" And we see somebody with an occupational therapist, social worker, and we see somebody for 2 or 3 hours, a longer evaluation, and then hopefully send them back to their primary care physician with more of a game plan. So I do that some. But I've had this great privilege to do a kind of a combination of things as a physician. So care for patients, work with patients and families through volunteer work around especially dementia, like you heard about the Alzheimer's Association, and then lately work at a national level in Washington, D.C. as a volunteer, not a paid person, but I was appointed to a commission or advisory council on Alzheimer's disease for the government. And I wanted to say just a bit about that. First, it's a privilege because I get, instead of having to choose to just work on policy or just do patient care, I get to do both. And it really informs what I say when I'm you know, on C-SPAN or whatever, because I bring the stories of real people and real families. Not to say I know everything about either side of it, but I think it is appreciated that it isn't just not an abstract concept, not a number, not a name of a disease, not an amount of money spent, but I try to reflect that these are real people and real families, and we need to do a better job with not just our healthcare system, but also the research side of things. So we do, I get to do that. And I think so I feel privileged that I get to do both. So just a word about that commission, because many of you would not have heard of it. The only piece of completely unanimously supported legislation in the last 4 years was voted 100% of Republicans in the House, 100% of Democrats, same in the Senate, was the National Alzheimer's Project Act. Okay, really, how many of you knew that there was 100% bipartisan? Not many of you knew, right? So what it was saying that it was sort of a recognition after years of really working with our elected representatives that Alzheimer's disease is a growing epidemic. Epidemic not because it's an infectious disease, but because of the number of people affected. And much of that has to do with the aging of the baby boomer population, the numbers of us that are being more successful in aging and living longer, and that gives us a greater opportunity to develop Alzheimer's disease, although there are 500,000 people younger than age 65 with Alzheimer's disease. That's a lot. So this isn't an entirely just a disease of aging, but it is a more significant problem as you grow older. Your risks increase with time. So we, the big we, not me and a few people, but a lot of people have lobbied our senators and our congressmen asking for the government to take a more specific look at this. Okay? The toll it takes on patients and families, the disconnected way our medical system works, the underappreciation and underinvestment in research. So this piece of legislation was proposed and passed, and what it did was to establish an advisory council, and there are 12 people who are federal employees, like the heads of the National Institutes on Aging, the Surgeon General, the Medical Director of Medicare, Indian Health Services, Veterans Affairs. I could go on, but there's 12 on that side, and then there's 12, like me, non-federal employees, and it's a little like Noah's Ark. Two researchers, 2 clinicians. I'm one of the 2 clinicians. 2 advocates in the sense of working for organizations like the Alzheimer's Association were chosen advocates for patients and families. 2 caregivers, and 2 people who work for state health plans. I think I got all those right. And so that's the commission, and our job is to give our recommendations about what should happen in research, clinical care, and long-term care and supports, to give our recommendations to the Secretary of Health and Human Services. Now, granted, that Secretary Sebelius has a big role in this, right? Under her is Medicare and funds to states for Medicaid, various things like that, aging services. But a lot of the things we're recommending take money to do. So she might suggest then to the president or to Congress, we are going to need this in order to do that. So I just want to tell you, yes, I do clinical care. I do lots of these kinds of events and work with patients and families and town hall meetings and things like that. So I'm equally, I don't know if I'm equally as comfortable in this and in Washington. I'm definitely less comfortable in Washington. I'm more comfortable here, but I'm privileged sort of to do both. So I have a little bit of an agenda of things that I want to cover, just a little bit of a primer, but I really care about answering your questions. So before we start, realize that was the longest introduction on record. Raise your hand and tell me a few things of why you came, in the sense of, this is what I wanted to hear. I wanted an answer or somebody to address this question. And give me a few of those, and I'll try to weave the talk around those a little bit. And then at the end, if I didn't do a good enough job, you ask me again or ask me a different question. And it seemed to work well yesterday when we did it that way. So what kinds of questions do you have? Don't be shy. Yeah.
My mother-in-law has vascular dementia that was caused by a stroke. And now she tends to have little delusions and hallucinations. Sometimes she gets combative. She hasn't been since she has her latest medication, but she has a lot of trouble knowing exactly where she is.
Okay.
She may think she's in a different city.
Just disorientation, yeah.
And she doesn't feel like she's at home no matter where she is. And of course, I moved her into my father's house. I moved her furniture in.
You're doing
everything.
what you can to do that. So your
So-
question is how to deal with
How do we deal
that.
with making her feel more
Okay.
comfortable in a familiar,
Okay.
you know,
Now,
surrounding?
just to be clear, that could be an hour talk, right? Okay, so, and not to belittle, it's a great question. And for whether you have Alzheimer's disease type of dementia or vascular dementia, that kind of challenge as a family or a caregiver comes up a lot, okay? How do you deal with disorientation, delusions, paranoia? So I'll go after that a little bit, but just know I'm gonna have to do the little bit of the Reader's Digest version on it in order to reach some other things. So give me a couple other topics. Yeah.
Can you define the difference between vascular dementia and Alzheimer's?
In my wheelhouse. It's coming right up.
And also dementia related to Alzheimer's.
Got that one too. Got that one too. That's why I have a little bit of set stuff because I know things that commonly come up.
So my name's Alex.
Hi, Alex.
I finished the medical assisting program. And I've worked a little bit with a patient with Huntington's disease, and then also some elder folks with
Dementia.
some kind of dementia, not exactly sure which kind. And one of the things, a paper I wrote was wondering about caring for not just the patient, but for the caregiver in terms of especially combative or violent patients, and if any research has been done. I haven't, to disclose, I have an agenda on that.
Yeah, there's a fair amount of research. I'll address that a little bit. Well, it'll kind of be similar to challenging behaviors. Yeah.
I'm interested more. I know a lot of the basics. My mother has Alzheimer's and her caregiver for many years now. She lives in assisted living. I'm interested in you and your role and what you could tell us about kind of what's happening in advocacy at
Okay.
the governmental level and the latest in research, although there was a recent great day conference, Circle of Care, that happened in
Good.
Foster City.
Oh, yeah.
They
I
always
thought
have
about, I got an
somebody
invite to
talks.
that. I couldn't rationalize coming so close
And
together.
They
Yeah.
often talk about
Yeah. No, they had
some of the
great,
latest research.
great leaders. Yeah.
Yeah. Just to take advantage a little bit
Yeah.
of your kind of.
So I'll try to say a little bit about that in the context of, yeah.
My name is Carol. I'm a parish nurse in San Francisco, taking care of.
Good for you.
And my question would be regarding the latest drug therapy.
Okay. Drug therapy. So I'll say a little bit about the disease and then by extension kind of research a little bit, and I'll try to do a little medicines. So if I get off track, pull me back because, you realize this is a windy road here. So let's first talk about what is Alzheimer's disease. In order to do what is Alzheimer's disease, I have to use the word dementia. So how many people here are real clear about the difference between dementia and Alzheimer's disease? You're clear about it. Couple of people clear. It's one of the common questions. Is all dementia, is that the same? Okay, so I want you to think of an umbrella that is the word dementia, okay? And the word dementia means you're having cognitive problems affecting memory and two other areas of functioning, cognitive functioning. When you think about what your brain does, it does a lot more than remember, right? You have language and judgment and prioritization and a sense of humor and abstract thinking and using calculations. So you need to have impairment in memory as well as impairment in two other areas that are noticeable to the clinician, and those have to impair your ability to function independently. Now, why is that so important? Because normal aging, everybody in here is older than they were a year ago, and all of us, it turns out that our memory and cognitive function is usually peaks in our 20s. So all of us, I'm looking for somebody younger than 20, I don't think so, we're on the downhill slope of our cognitive abilities. Now you could argue that you're older and wiser than you were when you were 20, and that is probably true. So maybe wisdom improves with age, but not necessarily. But for all of us, we have changes in our abilities, in our cognitive abilities, but we all don't have dementia. So what's normal? What are the common things in normal aging? We're all different because our short-term memories aren't as good as they were when we were 20. And the reason that we don't have dementia, though, is that we can compensate for changes in our memory by planning and effectively going around those problems. So when my husband says, and we're going to dinner with people, and what were their names again? He's thinking ahead to remind himself, because he knows he's forgetful of names. I could make jokes about this, but this was bad when he was 20 too. It's not all it's not all worsening. It's just a hole in his cognitive abilities. But he plans ahead so that he maintains his function, his social ability. When you think, I can no longer remember 6 things on the list to go to the store, you make a list. You plan for success, right? A person, so that's normal aging, but a person that is getting dementia can't effectively have insight into that problem and plan ahead to keep their functional level high. So they make mistakes with their memory. So first thing with normal aging, some impairment of short-term memory. Second, slower speed of processing. We can't do things as fast as we used to do when we were younger. Again, shouldn't necessarily impair your ability to function. You plan ahead. More difficulty learning new material as we get older. What used to come really quickly, what used to come, just hear it once and you've got it, may mean that you have to hear it twice now, or you may have to write it down and hear it, or you may need to read it and hear it. And you need to use different learning strategies than you did. You can still remember, you can still learn new things, but you may have to do it differently than you did as a younger person. So that's a change. And then difficulty multitasking. That becomes more challenging as we age. So instead of being able to hold all those balls in the air all the time, you need to focus more on one thing in order to be successful. Otherwise, all the things are falling down, right? So that's normal aging, but the caveat of normal aging is that you maintain your functional level pretty much the same, okay? Now, dementia is changes in your cognitive abilities. I told you memory in 2 other areas, but your functional level has now meant that you can no longer be independent. You used to manage your checkbook and finances, but now that doesn't work so well and you need someone to help you. That's okay, but that means you no longer, your level dropped. You were unable to do what you used to do. Okay, so that's dementia, and what did I say? It was an umbrella term. It is a broad term. So under that umbrella are all the kinds of dementia that we have, and there's Alzheimer's disease, which is the major cause of dementia, and I'll get back to that. Vascular dementia, which is little strokes or little scars, hardening of the arteries in the vascular system, and that's very underappreciated, and I'll try to talk about that in a bit. Then you have more unusual things like dementia from Parkinson's disease, mad cow disease, Lewy body disease, frontotemporal dementia, and football players and hockey players, you're seeing in the news, that's chronic traumatic brain disease. So somehow those bruising and scar tissue, repetitive injuries on the brain can cause dementia. And in many ways, it's very much like Alzheimer's disease. In some other ways, it's slightly different. So I want to say something. So that's how Alzheimer's disease is the major cause of dementia. But let's just think about that term for a second. We have known this word for over 100 years, and we haven't changed our understanding of it very significantly. Now, why is that? I want you to think back to the 50s and 60s and the word cancer. In the 50s and 60s, I was barely born. I was just a child then. That word, you would hear the word, you would think, that's terrible. Person usually dies with cancer, end of story. I mean, that was kind of what cancer was, a very scary word. It's still a scary word, but it's different now. When you hear that somebody has cancer, you say, what kind? Where is it? How is it found? What's the treatment? And you know that prostate cancer is different than colon cancer, is different than skin cancer, and you know that there are remarkable differences. All the research money we have spent from that war on cancer in the 50s and 60s and generating now $6 billion a year in research money has paid dividends in the advance of the disease. But that word, while every cancer has some similarities, I'm going somewhere with this, by the way, every cancer has some similarities, right? Cells that don't pay attention to their neighbors and grow. You know that there's really remarkable differences. They used to think there would be one cure for cancer, one thing, right? If we just find the one thing. And it's so clear that that is not the case. That different cancers are going to require different tests and to find them and different interventions. And they all need different keys to the lock, and yet there's some unifying things. Well, why I'm saying this is because this is exactly what I think is going to happen to Alzheimer's disease. And I'm not the only one who thinks that. I didn't make this up. That Alzheimer's disease is probably a mix, like cancer is, of some things that act similarly, but also act differently. If I asked how her mom is and how, you know, and I went through and asked about people, or I met people with Alzheimer's disease, there's some similarities, but there's some remarkable differences. People get this at different ages. Some people very early on have a lot of behavioral challenges. Some people have incredible lack of insight, don't believe they have any problems. You can't tell me that I have this problem. And other people come to me saying, I know something's wrong. I notice something's wrong. And they have tremendous insight into especially early on. I think that deteriorates. Some people keep their same personalities and are, you know, pleasantly forgetful and keep their same personalities, and other people are angry and their personalities change dramatically, and there's a lot of paranoia and delusions. So those are real big differences for the same disease. And I think what we're going to find, we're going to rename it someday, and we're going to see different ways. Come on in, please come in. We're going to see different ways of diagnosing things and different ways of treating it, kind of in the realm like cancer, I think. And that, you know, maybe that's in the next 5 or 10 years, I hope so. But let me just say that we have underinvested in this research tremendously. Whereas cancer, heart disease, HIV have gotten billions and billions of dollars, Alzheimer's disease got $400 million each of the last few years. And the numbers are staggering as to the effect on numbers of people. You know, 5.5 million people now will grow to 10 million in about the next 10 years and up to 50 million people. I mean, that's remarkable. This is a disease that takes people to care for people. It isn't take this pill and I'll see you in a month or 2 months or 6 months. That's not what this disease does. And people care, person-to-person care, is incredibly more expensive than take this pill and I'll see you in 6 months. And not only does it cost money to buy care, but families give a tremendous amount of care that's uncompensated care, right? I mean, the daughter that gives up the job in order to be the caregiver walks away from her retirement earnings, is not as employable when she comes back to the workforce, and there's a lot of lost productivity, wages, opportunity that we don't count very well in our economic, you know, toll of this disease. We try to get numbers around it. So there's a lot on the table here, and instead of spending a penny for research and $1 for care, which is what we do now, that math isn't going to work out so well for us pretty soon, because it's pretty soon going to be a penny and $2 and $3. And we don't have a Medicare system or an aging infrastructure system or a social system that's going to allow half of us to be taking care of the other half with dementia. Who's going to make things and you know, do other things? We're all going to be taking care of people who are aging. So I think, you know, there's no way to sort of grow our way out of this or anything like that. We're going to need to address it with research. On the research front, I'll try to circle around to medicines in just a second. On the research front, you know, I don't think we really, well, how many of you have heard of amyloid protein? Okay, a lot of you. So amyloid is a sticky protein that they find in greater quantities in people with brain injury, but especially with Alzheimer's disease, which is a degenerative disease of the brain. So there's a big controversy. There's some other changes in Alzheimer's disease. Well, what's the first change that happens? What's the first change? Are we just seeing amyloid because it's a scar? Because it's like the headstone on the grave that marks the grave? Because if that's the case, just like if you treat a scar, it doesn't make the injury better, you still had the injury. We need to figure out what's the injury, and that may be amyloid, it may be an error in how our body processes amyloid, but it may be some other trigger that starts it. So we haven't really answered that question, largely because it's difficult research, it takes a long time. We don't give you something and then sacrifice you and check your brain. We need one more chair. Anybody? Oh, we can give her this chair. Here you go. Please, help yourself. There's a chair. Because who would like to stand up the whole time? Not me. In terms of amyloid, I don't think we've answered fully that question. It is certainly part of the process of the disease process. And as amyloid builds up and other changes happen, cells in your brain die. And that's why the future really is not to take somebody who's already having symptoms, excuse me, might sneeze, and then try to treat them, because they've already got significant, by the time you're showing symptoms, you've already got significant loss of brain cells. So we're going to need a test that we find out someone 10 years before, 15 years before, it has the potential to develop this or will develop this, much like, you know, in babies and nurseries, they do a heel stick and they say, okay, good to go, or ooh, if we don't deal with this now, you're going to get this metabolic disease. Maybe it'll be a heel stick at birth for Alzheimer's, I don't know, but the same model goes. So we're getting much closer on that side of things, finding the markers that are good predictors of developing it, but we don't have the intervention yet to stop it. So if I had that test right now, which we kind of do, but it's not ready for public consumption because it's very expensive and it doesn't guide therapy at this point, so but say it exists. How many of you would want that test knowing that in the next 5, 10, or 15 years you would have Alzheimer's disease? How many would want it? Okay, a couple of you. Okay, I want you to ponder that a little bit, because I think ethically it would be a very difficult thing. We think we would like to know what the future holds, but just imagine how it would change your every single day. In some ways, good ways, right? Live in the moment, make good plans, but in other ways it would change everything about you and everything about what your choices are. So I'm not saying I know exactly the answer, but what we need in Alzheimer's disease research is a way to diagnose it before you have symptoms and a way to intervene and stop it. Yeah?
So given what you said, is there a genetic link to Alzheimer's disease?
Yeah.
So if I have a family member who has it, that predisposes me to having it also?
So like every disease, there's a genetic component, okay? So some fascinating research, I'll explain a little more about this, some fascinating research is happening right now in family clusters of the disease. And when I mean family clusters, I mean they have it bad. There's a family of 500 or so people in Colombia, and they know exactly with one genetic mutation that's pretty unique to that family who will get it, much like Huntington's disease, which is entirely predictable. That family is now getting targeted, intensive research to give them medicine at an early age with amyloid as what they're targeting, to see if by doing that they can either push it back or stop it from developing. The problem is that the majority of the population doesn't have that genetic mutation. It will help us know something more about general research and the role of amyloid, but it won't apply directly to everyone. So there's a few families, a small number of people with strong genetic mutations and risk factors, family clusters, but it's less than 1% of the people that get Alzheimer's. Most of us have different risk factors, and much like if your father had a heart attack at 50, you would say, ooh, I've got some genetic, that's in my family, right? It's on your past medical, or your medical history, you're saying, your family history, you're saying, father with early heart disease, that's a risk factor for you. You would think about it, but you wouldn't say, I necessarily at 50 am gonna have a heart attack, would you? You're gonna say, okay, I got this in my family and now I need to do the other things that mitigate that risk. The problem with Alzheimer's is that's the case for most of us, if we have a family, a first-degree relative with it, we have increased risk of developing it. It's not 100%, but we don't know all the other things you can do to mitigate your risk, okay? We do know a few, probably exercise and all the heart disease, vascular disease prevention strategies are probably very, very important. So that kind of bodes poorly for society, given that we're getting heavier and more sedentary and that kind of thing. So we really need to pay attention, though, because I think we have underestimated the component of vascular risk, vascular disease, and how it contributes. So having vascular disease doesn't cause Alzheimer's disease, but if your brain is already struggling with areas that aren't getting good blood flow, those areas can't hold off whatever the disease process of Alzheimer's disease is, like it needs to do in a really healthy way. You're already sick. Your brain is already struggling. And so in a lot of studies, if they go back and do autopsies, they find, oh, I keep thinking I'm going to sneeze, I apologize. I'm going to sneeze right into this microphone in about 1 second, and right on you. No, also, maybe somebody used pepper on their eggs up here, I don't know. Completely lost my train of thought on that one. Oh, vascular disease. Okay, good. All is not lost. So in vascular disease, if they look at studies, this really amazing study in nuns, actually, in a whole order of nuns called the Nun Study. And they were able to follow this group of women who had a very similar lifestyle, right? Lived together, ate similar things, you know, cognitively pretty similar levels of education. And they did cognitive testing with them every year. And some of them over time were developing dementia. They noted that. Some were functioning really well and not. But when they died, they all had autopsies of their brain. Okay, they had all agreed to this before, obviously, you know, the whole order had. And when they looked at these women's autopsies, they noticed really interesting things. If somebody had dementia at a certain point, and they went and looked, they either had Alzheimer's disease or vascular dementia by and large, and they were pretty good at predicting that. But some people, they might go in, they say they had moderate dementia, and they went in and looked, and they said, oh my goodness, the Alzheimer's plaques and tangles are terribly severe. They looked better in life than their brain looked. But in those people, they had beautiful vascular systems. Really, no mini strokes, very healthy, okay? The other side happened too. Somebody who, instead of, you know, at a certain point, they go look at the autopsy and they said, wow, there's not much Alzheimer's disease pathology at all here. They were worse in life than what the brain showed, but they had vascular disease. So that vascular disease means that that circulation plays such a big role that you're going to show your Alzheimer's disease much earlier, okay? So I used this analogy yesterday. I made this up, so if it doesn't hold a huge amount of water, you can criticize me later. But it's as if we all have a thermostat, every one of us, for Alzheimer's disease. The families that get it, they're dialed hot. The person for Alzheimer's disease, you know, on the thermostat, right? It's like having an aggressive cancer, having one that you can't throw anything about it, you're going to get it early. If you hear about the 50-year-old, the 45-year-old with Alzheimer's disease, that's dialed hot for Alzheimer's disease. There's a few people dialed really cold. These are meaning they're cognitively well and they have bad habits. You know, the George Burns smoking a cigar, scotch in one hand, you know, making jokes till he's 105. He wasn't at very high risk for Alzheimer's disease. We got to figure out what's in the water for him, right? We got to figure out, we want to be more like that, sort of. But the majority of us, probably 90% of us, our risk of developing Alzheimer's disease is going to go up as we age, and we're all dialed kind of medium, meaning we're going to get it if we live long enough. But that medium means, I don't know for every person, but you know, 78, 75, 82, that's where we're set for getting it. If you take care of your vascular system, if you exercise, eat well, stay mentally, socially, cognitively stimulated, you might take that 82 and move it back to 88 with your habits and modifying your risk factors. And I also said we don't know all of them yet, right? But if, on the other hand, you're dialed for 82 and you sit around and watch TV and smoke and don't control your blood pressure, your cholesterol, your blood sugar, instead of 82, you're getting it at 75, right? You're going to show your first symptom earlier. So that's what's underappreciated about Alzheimer's disease and vascular disease, is that they travel together a lot in people. That doesn't mean Alzheimer's disease is less of a disease, but it means, in a way, somewhat encouragingly, that we have some control over some aspect of developing it. Not 100% control, though. I mean, I just diagnosed a 51-year-old woman who ran a marathon, a few months ago. Very healthy, doesn't do anything wrong, but she's dialed hot, right, for Alzheimer's disease. So that's a little bit about where research is going, names of dementia, medicines. We do not have a cure for Alzheimer's disease. We do not have a cure really for any dementia. The evaluation for Alzheimer's disease and other dementias is one where we're, yes, trying to diagnose it, but we're also trying to get ourselves reassurance that there's not other problems causing the cognitive impairment. So medications, other medications, how many people take a significant amount of Benadryl or other anticholinergics that worsen their memory is a real problem, or other medicines, bladder medicines, etc. Your thyroid function, sometimes rare infections and other things. So we spend more time thinking, what else could this be? And can I try to change that before I can really feel with confidence that this is Alzheimer's disease? That's a little bit about the diagnosis. But there is no one test, no CAT scan, no MRI scan, nothing like that that says, aha, this is it. We may have other tools in our armamentarium soon, like lumbar punctures, looking at spinal fluid, that may add predictive value, or special scans, but those will come at great cost. And we're already talking about an illness that a lot of people have, and I haven't convinced many people that they really want to go have a spinal tap in order to have this diagnosis, especially when I don't have a treatment that can, catch it. So not the most embraceable test as part of a workup for an 89-year-old, but it might be useful in the future. So we'll see. Any real advance in finding this early, I think, would be helpful. Medicines that we do have are best used early. So you might say finding it early gives you the best chance to use medicines. These medicines do not cure the disease, though. These medicines help augment your brain's ability to work better for longer in some people, but not all of them. These are not antibiotics that if you take this will cure this infection. It's not like that. And the problem is that if I was seeing you, for example, I don't know anything about this, I'm just using our example. And if we diagnosed you with Alzheimer's disease, I could not predict in advance whether you would benefit from the medicine or not. I need that little Star Trek-y Dr. Spock thing that goes, yep, she's going to benefit from the medicine, and then great, I'm going to get that for you. But I need to give everybody, when I make a diagnosis, I need to generally give them an option for taking the medicine. 60% of the time it's beneficial. The longer we wait into the disease, the less chance it is to be beneficial. And what do I mean by beneficial? So here's a typical story. When someone takes it, the family says, remembering a little better, a little brighter, remembering my name a little more. I leave him a note to warm up what's for lunch and to warm it up in the microwave with the directions on how to push in the buttons and start. And it actually is working now. He's actually warming his lunch again, or using the remote control. Not going back to work, not that level of improvement. But you know what? If that does something good for that person and they're willing to pay the $100 a month or so that it takes for the medicine, and they're not foregoing food for it, then, so be it. That's helpful to them. But I let the patient and the patient's families decide about that. I think that's ethically the right way to do it. if it was a cure, and even if you didn't want it, I'd force it down your throat. No, I mean, you know, we would do a lot to get medicine in people. I didn't just say I would force it down your throat. You know what I'm saying? If something's a cure, we would work really hard to get it out to people, but that's not what these medicines are. And what these medicines, Aricept, Razodine, they all have drug company names, Exelon. Namenda is slightly different, works in a different way. The other analogy I use for this for those of you that aren't, you know, I don't think it's helpful to really talk about what's the mechanism of the disease, but of why the medicine works. But how many of you have heard of or know someone that takes a pill for diabetes, takes a pill for their blood sugar? How many of you? You do it. I now can use you as an example, really, truly. No, okay, no, don't give me the pill. So here's the disease. Here it is. You know what this does. This is an oversimplification, but when she takes that pill, she's telling her pancreas, come on, pancreas, work harder, release more insulin, be more sensitive to the effects of insulin. It doesn't give her a new pancreas, right? It doesn't replace insulin. It just tells her pancreas to work harder. Hopefully it'll work for a long time, but at some point people need to move to insulin, usually unless they die of something else, because no longer can that pancreas deliver even with that stimulus. Well, the medicines for Alzheimer's disease are like that pill for diabetes. They're saying, come on, brain, come on, do better, be more efficient through the use of neurotransmitters. And when that no longer seems to be helpful, we just don't have the insulin, right? We don't have the next thing. It's a lot more complicated than that. But I think that if you understand the medicines for Alzheimer's disease like that, like the pill for diabetes, you get them. You get them. They can be helpful. They might be helpful for a time, but there will be a time when they aren't as helpful. So, okay, so that's a little bit about medicines. I was going to say a bit about the clinical stages and then talk a bit about planning and transitions. So there's a lot of different ways to talk about the stages. You could divide them in, 18 ways and, various tests. And researchers do that in order to be sure they're testing, apples to apples to apples. But it's easier just to say, it's fine. Mild. By the way, if anybody needs to get up, use the restroom, if you need to go, it's perfectly fine with me. We will not insult me. So let's just say mild, moderate, and severe, or mild, moderate, and advanced. So what's mild? Mild is somebody that's newly diagnosed or showing significant signs, and they're having more problems with probably memory and organization, prioritization, than most things. Some people have a lot of language problems early, but usually in mild disease, prompts and reminders help, okay? Making a list helps them stay organized. Reminding them, oh yeah, got it, oh yeah, I remember where that is now, and they can use that prompt and reminder to keep their function. Not perfect, but it works, it helps. As you move into moderate stage, those reminders and prompts don't work as well, and you then need to begin to do a little more for the person, not just remind them, okay? Especially you can't give multi-step commands, because they might remember the first, but the other commands or reminders fall by the wayside. And obviously in advanced disease, you need to do almost everything for the person, from bathing, dressing, basic decision making, help with feeding, and ultimately, because this disease starts in the brain in a way that just affects thinking and moves over time to more broadly affect what your brain does, walking, balance, swallowing, speaking, ability to speak, etc. As it generalizes, then you're seeing more general neurologic problems. So what starts out as memory alone spreads over time to other parts of the brain and other functions of the brain. And that's why why does a memory problem disease ultimately affect people's ability to swallow? Well, that's why, because it's broadening in the brain over time. And so someone typically in very advanced disease, if you don't die of other things and you live as long as you can for your body with Alzheimer's disease, you need to be fed, you don't speak, you sit, you don't walk, and you have difficulty swallowing. So often people say, can you die of Alzheimer's disease? And you absolutely can. Even though it's listed as the 6th leading cause of death in the country, it's much higher than that. And the reason is how we count that is what's on death certificates. And when someone dies because they have stopped eating well, or they've gotten repeated pneumonias from aspiration or food going down the wrong pipe, what goes on their death certificate is pneumonia. And it's only a very thoughtful physician that spends the time to say pneumonia caused by dysphagia or difficulty swallowing, caused by Alzheimer's disease. And when that gets on the death certificate, then that person gets counted for having that. So we're undercounting this as a cause or a big contributor of death. So you do die of Alzheimer's disease, infections, trauma, weight loss, and just frailty, failing over time. And so it is not just, it's important to realize that it's an important cause of death. Why? Well, research money goes to things that are the leading causes of decline in death, and that's something what we're trying to bring up at the government in terms of policy and making policy decisions. So in terms of those stages, there is no right. So if you look at people, often at the beginning of the disease, more people live at home or in a home-like setting or where they've been living early. And over the course of the disease, of course, more people transition to living in facilities. And about 70% of people who die with Alzheimer's disease are living in a nursing facility or assisted living with augmented care at the time of their death. So it changes over time. But one common question I get is, when is it time to think about that transition? Now remember, at 70%, there's 30% of people who are dying at home, and that takes a bit of luck, because you have to be in a family or have resources that can do home caregiving in a 24-hour, 7-day-a-week, 365-day-a-year thing. And not everybody's lucky enough to have that. I mean, kids move away. My dad reminds me that of all the time. I left for Maine and he's in Southern California. Thanks for that, he says. But that's the way of modern society now. We don't stay around our neighborhoods and in families. So that really impacts the ability of caring in place and keeping someone at home. But there's no exact right time to transition. It's really individual about the person's needs. Challenging behaviors are one of the most common things, and sleep deprivation, sleep disorders, night-day inversion are one of the most common reasons why people transition to needing to be in a facility of some sort, because that's really hard. So challenging behaviors, when I talk about those, that's restlessness, agitation, anger, depression, eating challenges, paranoia, delusions, hallucinations. And we don't have good solutions for those. The bedrock and most important solution at times is for everyone, is to try to understand where that behavior is coming from. Now we could do an hour just on this, right? So I'm going to make this, I have to make this really short so I can do other questions. But if you can understand a little bit about what triggers that behavior, what time of day, what scenario, what environment, what kinds of things trigger it, then you can go a long way to going back before it and changing the circumstances. I'll give you an example. I gave this example last night. Lovely older gentleman and his wife come see me, and when I first met them, he knew she had dementia, which is Alzheimer's disease or mixed dementia with vascular disease. And he came because he said, I need a medicine. I need a medicine. She, every day around 3 or 4 o'clock, gets very upset and she wants to go home. And he goes, but it is her home. Now he's in his mid-80s, okay? So this is a really hard thing for a gentleman who's been cared for by his wife. Generationally, this is what's happened, right? She did everything. And now all of a sudden, he's cooking, he's doing the errands, he's shopping, he's caring for her, he's having to dress her and bathe her and things that he just is, you know, overburdened to do. He wasn't trained for this, right? He's doing a remarkable job, and I needed to give him a lot of positive feedback for what he was doing. But at 3 in the afternoon every day, she wants to go home. And he tells her, this is your home. I'm your husband. This is your home. And she goes, no, I want to go home. And the home she wants to go to is her childhood home. And she wants to be with her parents. She's 85. Her parents are not around anymore. So for a while, he tries to remind her, tell her, no, this is your home, this is me, this isn't going well. It's a battle for several hours, and eventually she gets tired of crying and railing at him and trying to leave, and he keeps her from leaving, and she gives up, and she's exhausted. He can barely get dinner in her, and she goes to bed. So he comes to me, because what he has done in coping with this over time is, you know, wonderful man that he is in some ways, is thinking, I can do better. I'll try to stop this tomorrow. He then starts driving her to the cemetery to show her the graves of her parents, and makes her get out of the car. This is Maine, so winter included. But they get out of the car, they look at the tombstones. Your parents are dead. You don't have a house anymore. I'm your husband. Live with me. See? Can't you see? And then he takes her home. She cries on the way home, but then she seems a little better by the time she gets home. Okay, but he has now made her live through the death of her parents every day for the months before. I didn't know whether to laugh or cry. Okay, laugh and wanted to hug the guy for caring so much about her that he was doing anything. He was trying to make her stop being upset. And he's trying to use reality, you know, don't you remember, you know, look at this. So I wanted to say, good for you for trying, but oh, I wanted to cry. Oh, I'm so sorry she has to live through the death of her parents every day, that you remind her of this painful thing. So what we tried to do with the behavior, and this is a little bit like teaching an old dog a new trick, because he was pretty set in his ways, was to say at some level she's reminiscing. She is wanting to talk at that time of day. She's got this thing going in her brain like a crossed wire, and she's thinking about her family and her home. You telling her what is true is not working, but it's almost like crying out for some discussion of that or something with that. But let's see if we can't change the terms of the discussion. Let's see if when she begins to say she wants to go home, well, even before that, step back. What's happening in the afternoon before that? Is she getting food? Can we have her be doing something different to distract her or engage her in something else? Change the table setting, so to speak, so that the behavior it always happens at a certain time in the afternoon. She's always sitting in her chair. Let's change the setup. And then if it begins to happen, let's see if you can't. Let's make a scrapbook of family photos of happy things in her family, sisters, brothers, friends, neighborhood. Go around, take a picture of the old house, do whatever it is. And when she starts doing this, sit down and start talking about happy things. Do you remember when your sister, she didn't like me when we met. She didn't want us to get married. Remember, she did this to me. And remember your dad, you know, and see if that kind of context lets her talk about her family and remember them, but you've done it in a different way than remind her of loss and confrontational. I wouldn't say that works all the time, but it's changed the dynamic. She's still agitated in the afternoon, but no medicine was going to make that better. I could make her sleepy. I could make her a little less agitated, but all the medicines for the psychotic features, the delusions and things like that, they come with a price. Not just a price of money. They usually decrease function. Not to say that I never use them, because when your goal is to improve and to maintain or improve people's quality of life, if they are so distressed and no amount of behavioral changing, caregiver changes, facility, you know, place of living change, you know, activities, if no amount of that is helping, then we will try medicines, because we will say, we're at the point where accepting some changes in someone's function, and remember all those medicines increase slightly your risk for heart attack or stroke as well. I don't know why, but they do. But you might be willing to take that risk or that possible side effect if it can be the right key for their lock and decrease their distress. What are some other questions that I didn't cover that you wanted to hear? I'll do my best.
To what extent are word-finding problems related to Alzheimer's, or are they related?
So word-finding difficulties are really often very characteristic of Alzheimer's disease. So it's not 100% of the time, and some people have that as an early component of the disease.
You might define that for people who don't know what it is.
Word finding means finding the right word for things. So a typical thing is looking at the what. I'll just use an example. Look at the what. You know that thing, the thing. The thing that tells time. Now, how many of you have had word finding difficulties? All of us have word finding. In fact, it probably freaks me out when I have it more than it does you, because this is my life of not finding words. But I mean, it's kind of like, you think, oh great, I can't think of that word. But it happens to all of us. And as in normal aging, it happens when we're busy, stressed, multitasking, thinking of other things. So when it happens to you, you need to go, whew, it'll come back. Just think about something else, and it usually does. But when it is part of this disease process, Alzheimer's, it gets worse over time, and you begin to see it in conversation, normal conversation. So sometimes people will stop, they'll say, ooh, I don't know that. But what generally happens is they'll put word substitutions in, thinking, oh, that's good enough, that's what comes up. So instead of watch, it might be clock. And even though you might pick those things up. So when I'm testing somebody, there's a standard battery of tests where you can look for problems with word finding. What's challenging, though, is that people with higher levels of education and vocabulary, they have spent more time enriching their language and vocabulary. Maybe that's lucky. They had the chance for a lot of education, or they spent a lot of time reading. So it may take me or somebody else, it might be harder for me to determine it, but they could have the same level of problem, okay? So it just gets, it is a very common part of Alzheimer's disease, but just because you have some of it doesn't mean you have Alzheimer's disease.
I have a friend who has, every time I see her, which is several times a month, she has several of these episodes every time I see her.
Yeah.
She doesn't have intrusions, but she'll say, what do you call it, or something
Yeah.
like that. And she recognized it herself. Her son even made her go to the doctor because I think he was afraid that she had Alzheimer's. She does not have any memory problems that I'm aware of. I don't know any other symptoms. But it's, every time I see her, she has at least 3 or 4 of these episodes where she says thingamajigger or what you call it, or,
right.
or whatever. So
So
I don't know.
So a couple of things. So well, you may have a question of like, how do you handle that as a friend? Do you give the word? Do you not? I'll take that in a second. But if you notice this in somebody, you do get concerned. And if she truly has no other deficits in her other domains of cognitive functioning, then it's not true Alzheimer's disease. There is a very unusual kind of dementia called primary progressive aphasia, or PPA. And that subgroup of dementia is very subtype. It's a subtype of like Alzheimer's disease, but it's affecting language far and above more than it does memory. Ultimately, memory does get affected. But that would need a neurologist, usually a behavioral or cognitive neurologist or a neuropsychologist, to dive a little deeper. So I would say, hey, good idea, go to the doctor, check it out. Of course, I can't know what the doctor did to reassure her, whether he or she was a good doctor. But if it's getting worse, I would say take the next step and get a more specific evaluation from a neurologist or behavioral neurologist. All of us have that question, especially if you work with people with dementia, when they search for a word, or maybe it's just your friends. It's my husband sometimes, it's me sometimes. Do we provide the word? Is that a helpful thing? Do we help, or is that demeaning? And I think you have to just follow your own compass on that, because often if somebody's looking at you like, help me out here, you're not going to go, well, just, good luck with that. You're going to help. If, on the other hand, they get ticked at you because you're giving them, I would have had it, then that's not helpful to them. So you just usually want to check your own desire to correct, and at least for a pause, for a beat, let it sit a little bit. And if you can, often as a doctor, one thing I'll do, and it happens a lot in my exam room, is I can often guess what the word is that they're trying to say. I tend not to tell them what the word is, but just act like I understand what they're trying to say, if I do, and just go on. So in other words, I'm minimizing their deficit. And in fact, it's kind of a broader point, and I didn't bring it up yesterday, so you're lucky. Today, you get the point. Is that my whole job in what I do, well, as a human being, but also as a physician, is to make, and all of us, if you're a caregiver, interact with folks or family member, our job is to make the person as much as they can be, okay? It is not to minimize them, it is to maximize them in terms of their quality of life, their experience, their sense of self and dignity. So if I make somebody feel bad for their deficits, I'm minimizing them, okay? So if I can just carry on the conversation, even though it has gaps or, clock instead of watch or shoe instead of hairbrush or whatever it is, if I understand what's going on, I make them feel like we're like a human being. I'll do my best to that.
Can you supply the word for them? Because
sometimes, but if I do that so much, then not only does it make the conversation go like this, it gets very chopped up, but they begin to feel diminished.
Or dependent on you.
Or dependent. Yeah. Now, I can't help the dependent part. I often see couples where one constantly looks to the other for help. Now, that's a coping mechanism, but it's also a bond and love, and that's the person that knows them. So I have to support that to some extent. And sometimes I'll intervene in families or couples or whatever when one is really hard on the other one. And I'll pull that person out and say, listen, I don't know this is tough what you're doing. This is really hard, emotionally, physically, all of it is hard. But it is not going to help you to make him feel worse about what he's forgetting. It will make him feel worse. It will ultimately make your caregiving worse, and you don't want to do that. But that's a sign of caregiver stress, by the way, or pathologic personality. But it's a sign of caregiver stress. I get to come to work and do this for some hours. I don't do it for 24 hours a day. In fact, my husband says, boy, you have no patience with me. And I thought you were around people that forgot people's names all the time. And I go, yeah, I'm better at work. But that's probably true for all of us. But remember, when somebody is acting that way, they're very stressed. And that relationship, then really we need to pay attention to it, because then that person is at risk for not getting good care, both of them really, and abuse, physical or neglect or things like that. So we have to pay attention to that when I see that. So, yeah.
So, as a caregiver or as someone who's, trying to live a normal life as well as give care and all.
Good luck with that. Normal? You have a new normal.
When you get really stressed yourself, and all of a sudden you find yourself coming up with the wrong word or not being able to find just the word you want. You're able to express yourself, but you have to use like 5 words for the one that you used to be able to use. Is that kind of a stress syndrome?
It usually is a stress syndrome, yeah. So I think just knowing what some triggers are for your own health as a caregiver and your own stress level, and then, it's harder for me to tell you what to do to relieve that stress. Everybody has different supports, different options. But, whether it's respite care for the person, daycare, I know you have a good caregiving situation, but maybe it's doing something for yourself more often, taking a break. Maybe it's putting exercise back into a schedule that it dropped out of because of being busy and being a caregiver. So there's a lot of approaches. For some families, it's beginning to work on a transition. Do you know that caregivers of somebody with dementia, this was done with Alzheimer's patients, not only do they have a much higher risk of dying, okay, but they have a higher risk of heart disease, depression, diabetes, hypertension. So not just depression, which you think, okay, we can kind of understand that this is really emotionally hard and you might be more, but actual physical illnesses. And when they look at that level, that caregiving relationship, and they say, okay, well, what is it? Why does somebody do well and not? If you sense burden and stress as a caregiver, then you're more likely to have these bad medical outcomes. But if they looked back and they said, okay, you know, look at these people at all, she might say no stress, even though she's doing 24-hour-a-day, 7-day care. You might just be managing, you know, from the East Coast to the West Coast, but you get some phone calls and you're kind of doing it from a distance, but you're not doing direct care. But you might feel stress about that. If you feel stress, it doesn't matter, burden or caregiver burden, it doesn't matter how many hours you do it or whether you're the direct caregiver, you are going to get those, you are likely to get the bad medical outcomes. That's why this is not just a disease of one person, but we have to look at the whole caregiving environment, the family, the support system, because it affects everybody, right?
I was curious about, particularly in the early stages, and also trying to determine whether it's true Alzheimer's versus just general aging. Are there physical ailments or physical symptoms?
Great question. Up until recently, I would have said not hard and fast, but recent research is showing early changes in walking and balance ability and speed of walking. That you can look that up on the Alzheimer's Association website, alz.org, which has a lot of resources, by the way, as far as caregiving, research updates, choosing times of transition, what are your community options, education has a lot of stuff. But you can look up that research, and it's very compelling research. Again, would you, if that tells you you're developing it, you know, it would be helpful to clinicians to have something like a blood pressure is, to, you know, something tangible, mini mental status and aside. So it might be helpful, but until we can intervene, it's just telling us. But there may be early signs in balance and walking. Some people have thought changes in smell and taste. In some people, that's definitely true, but not in everybody. So that hasn't borne out to be true for so many people.
I'm actually from the Alzheimer's Association, and yeah, in terms of the walking, we've heard a lot of caregivers who've taken their mothers or fathers in because they kept falling, and it turned out that they had, in the process of developing Alzheimer's.
The problem is there are a lot of people who have balance and gait disorders that don't have Alzheimer's disease. So there's a lot of reasons as we age in terms of how complex walking is. Arthritis, neuropathy, proprioception, back disease, eyesight. You need your eyesight. You need good posture. If you're like this because you have osteoporosis, your visual spatial ability. So there's a lot of other inputs into walking. But even controlling for that, it looks like early on people that are developing Alzheimer's disease have more problems walking. We have not yet figured out a way to use that yet in clinical practice. It really just came out, but it's very interesting. There may be early physical signs there, and then I'll go to you next. Yeah.
I know that depression is a common comorbid thing with Alzheimer's. How effective are antidepressants to, you know, help with mood?
Yes. Her question is about how often we see depression or symptoms of depression along with Alzheimer's disease, and how effective are the medicines. So this is very tough, and if I had an answer to that question, I would be famous. I would be so famous. Maybe not the Nobel Prize, but quite famous, quite famous. Well, just because when you think about it, there are a lot of people that have depression in the world, right? Not all of them will develop Alzheimer's. So some people have that challenge before they develop Alzheimer's, okay? Some people get it coincidentally right around the same time. And if you think about the challenges that you're dealing with and coming to terms with it, if you are coming to terms with it, that's a pretty good impetus for depression, I would say. And then we also see people that develop signs of it later in the disease, and then we wonder, boy, is this the disease doing this? Or is this really the same as a 30-year-old getting getting depression? And the answer is we don't know. So there are features of Alzheimer's disease that act a lot like depression: isolation, apathy, withdrawal, loss of normal social contacts, and things that you used to like to do that you don't do anymore. You could read those as depression, or you could read those as signs and symptoms of Alzheimer's disease. So in other words, it's an unanswered question. If I have somebody with very prominent symptoms of depression, apathy, isolation, loss of enjoyment in things that they've done, maybe sadness and tearfulness, if they have significant other cognitive problems, I have a decision about which one is bigger at that point and whether I want to go trying the Alzheimer's medicines, saying, come on, brain, and seeing if those behavioral or emotional symptoms follow along with some improvement, or do I want to go right for the depression symptoms? And one thing I don't want to do is start 2 medicines at once. Okay? Never do that, because number one, you don't want to use a lot of medicines. Number two, I'll never know which one was effective, so you never want to do. So I have to pick. The challenge is that both of those medicines may take weeks and months to show improvement. One thing I'll do when I think depression, especially apathetic depression, is a real difficult problem, is I'll use Ritalin. So the person that doesn't want to eat, doesn't want to do anything, is just, morose and sad and slow, and, because that works very quickly. And it also comes out of the body very quickly. If it's not helping, I can stop it. So we'll use that a lot, and we don't have to wait, like with the Zoloft and the Celexa and stuff, you have to wait weeks and weeks before you know benefit. So they're tangled. They're really tangled. But I do think it's important, one of the things when I talk to other doctors is to say, just because someone has dementia and they're really sad, that doesn't mean we give up on that. We may not be able to cure the Alzheimer's disease, but we can work hard at treating all kinds of symptoms, okay? And really improve, that's pain, that's anxiety, and not all of it's medicines, but we need to look for the things that we can really improve, because we need to improve quality of life.
Yes, let's say that you find somebody in your practice that needs a conservatorship.
Mm-hmm.
Can a primary medical doctor diagnose, or do you need a specialist?
When you say diagnose, okay, so primary care physicians can do diagnosis of Alzheimer's disease, and many do, but it takes a good chunk of time. And the way we have set up our medical system, which is one of the things I'm working on in Washington, D.C., the way we've set it up is to reimburse them more for seeing a lot of people fast. And that is not what this population needs. So we're working on trying to get more comprehensive codes that encourages someone to spend an hour talking with the family, talking with the patient, and really sorting this kind of stuff out so you can do good advanced care planning. This is what you're going to need for financial power of attorney, for healthcare power of attorney, and doing all that and be fairly reimbursed for it. That really doesn't happen very easily. So there's a big deterrent for primary care providers to do this well. I'm not saying it can't happen, but it's hard for them to do it. They don't feel like they have the tools sometimes, and they're not reimbursed well for it. So you often have to go to a memory clinic, geriatrician, neurologist, who's kind of more set up for this. But when you say conservatorship, she's talking about substituted decision maker for someone to do financial, legal, healthcare power, aside from healthcare. That's a slightly different thing, because what we say is that when people, for any reason, don't have decision-making capacity, can't fully appreciate the risks and benefits of their decisions, the society says someone needs to step in to do that. Whether they've had a brain injury, whether they have had a stroke, whether they have Down syndrome, you know, and they're younger, we care about their welfare, right? And someone needs to be empowered to make their decisions. So when you say, in order to decide about a conservatorship or a guardianship, you have to do a capacity evaluation. So not everyone with Alzheimer's disease is incapacitated. And I would also say that when there's problems with decision making, Mom, you're leaving the stove on and causing fires. No, I'm not. It's not a problem. You begin to worry about that person's decision-making capacity. I'm just giving one example. There's many others. But then you need to sit down and say, okay, it doesn't mean you can't have capacity to make every decision, but what ones are the ones that really you struggle with and how? And that's a whole different evaluation than a diagnostic evaluation for Alzheimer's disease. And I'll reach out to neuropsychologists sometimes or psychiatrists sometimes. I personally do capacity evaluations too when asked to, and it's really different. So it could be any different combination of diseases or states, and what you're looking at is, how is their memory? That's important, and you have to know you need to make a decision and remember what it was. You need to be able to manipulate information, okay? If I give you risks, there's a 70% chance of this happening or whatever. You have to be able to manipulate that information. You have to be able to state the disease and give me state the problem and give me a reason why you're going to make that decision. You need to sustain your choice over time. I had the most frustrating case last week of a gentleman with some dementia and also some other physical illnesses that was in a really tough spot. He was on dialysis. He needed an amputation. You know, it was really tough. He was approaching the end of his life, right? But he didn't want that. And the choices were this or this or this. But he goes, I want different choices. You know, there's got to be more choices. And I go, yeah, not so much. We got these choices here, you know. And he'd make a decision. Okay, this is what I want. No, I want this. And then I say, okay, now you're feeling good about, you know, this is a big decision. He's like, no, I want to go back to this decision. And he couldn't sustain his choice. He couldn't remember the things. And so I said, this person does, as much as he wanted to participate in it and we needed to listen to his strong preferences, he really wasn't capacitated to fully do that. And this was in the hospital, and I said to his sister, as much as you don't want this role and responsibility, you are his substitute decision maker because he really can't. And she understood that, but it's a really hard place to be when you're talking about life and death kinds of decisions. Way back, yeah?
What are your thoughts on antipsychotics to treat behavior problems?
Well, I think I spoke about that a little bit. Antipsychotics, so antipsychotics are medicines that were designed for schizophrenia and bipolar disease. They're the Zyprexas, Seroquels, Haldols, Risperidols, those medicines. Now, I don't paint them with a tremendously dark color. You know, I am not their big fans, and I'm not their big hater either. I do think that they got overused for a time, and when we use medicines for our convenience, to make somebody behave in a way that helps, you know, that helps me caregive for them and makes them more compliant, that's wrong. You know, and that's why I went into the part about thinking about the behavior and thinking about the environment and how I'm caregiving and what am I doing or the situation doing to cause the behavior. And that should be job one. If all of that has happened and you have done a really robust job of doing your best and the person is still very distressed or they're a danger to themselves or other people, the person that walks through a nursing home and just keeps slugging everyone else, that's a problem. And we can't keep them apart from every other person in that nursing home all the time. We can do our best, But that just can't happen in a at that point, because they're a danger to other people and we can't change the environment entirely, and you can't make them walk around in a straitjacket or tie them down, which would be bad for them, then we often use medicines. But those medicines come at a cost of function, usually. Every once in a while, it is like a home run, brilliant, wonderful thing. You find a little key to that lock and it works great. And I would say that happens maybe 1 out of 10 times. The other, maybe 1 or 2 out of 10 times, they do very badly functionally. They aren't eating, they aren't walking as well, and you need to take that medicine right off and try something else or give them some time off of it. But in the middle is a lot of times where, yeah, the agitation and the behavior is a bit better, maybe more tolerable, maybe improved quality of life, but it's coming at a cost of their function. And then we have a conversation, who's ever in the care team, about, is this a balance we're willing to strike? Okay, we were here, this is what was happening, it's a bit better and maybe improved quality of life, but they're not feeding themselves anymore. Is that acceptable? This might mean that their life ends earlier if they aren't eating as well or not walking as well, or they maybe fall. Is that a compromise we're willing to make? Because before, without it, they were tortured. I had a woman who lived through the Holocaust, and her behavior was believing that people were coming again to take her and her family. I could reassure her, and everybody did, let me tell you. If there's a more wrenching paranoia or delusion, I don't know what it is, because it was real, or at least the stories were real. And in her memory, it was very real. And I won't know what she actually experienced. We can't let her do that. We couldn't tell her it wouldn't happen. She didn't understand that. It was a psychotic symptom, or it had magnified to that point. So we were doing everything we could ultimately with medicines and every aspect we could to relieve that. It was better that she didn't have that tortured existence and maybe not quite as functional. And we all kind of agreed on that, family included. So I use them, but we try very hard not to overuse them. We try very hard to do other things before it. We should not use them as convenience. They should not be a knee-jerk response to a problem behavior.
Can I just piggyback off of that?
You bet.
In just one specific drug, meaning Haldol.
Yep.
Here at AlmaVia, we definitely have the non-pharmacological approach as well.
Yeah.
And we do the best that we can with activity programming.
Uh-huh.
And we have had certain situations where residents have done harm to themselves and others,
Yeah.
let's say, and different doctors have had different medications. In our observations, Haldol is one drug that has, in that 1%, really worked well. And we've seen a positive improvement in the quality of life. Mm-hmm. But then on the opposite spectrum, you have a complete downshift. And it's one of those medications that we have to monitor around the clock.
I think it's actually true for all of them. You could see somebody having the same response to risperidone or Zyprexa. I've heard all those same stories. My thing about Haldol is, Haldol is slightly different. It's a typical antipsychotic, where the others are called atypicals, and they work a little differently. Haldol's really cheap. The others are really expensive. Yeah. That's an important thing to point out. So drug companies have really, really marketed these atypical ones more because they make more money. In reality, what I think the difference maybe in some cases is that, and how they're able to say, oh, these work with less side effects than the Haldol, is that the doses of the Haldol used to be quite high. And when I use Haldol, and I will use it, I'll use 1/4 of a milligram, 1/2 of a milligram, not 2, not 3, not 5. Start with little bits. Yeah. And you usually don't have as much side effect problem when you use that. But I feel, I don't believe that there's that much difference between the classes of the medicine, and the research isn't showing that. They both have side effects, but I think it's often a dose problem. But you need to have a healthy, we won't do much more on medicines, but you need to have a healthy respect for this class of medicines. They are not perfect, easy to use medicines, and you need to constantly evaluate them. Mm-hmm. So when I write an order for an antipsychotic, say in a nursing home or a hospital, I say, blah, 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 Yeah, that was medical school right there. Blah, 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 blah. Big money in that. Anyway, you write that, and then I say, please call me if you see changes. So I'm writing this to the nursing staff, so they have to put this in the MAR. Please call me if you notice changes in eating, sleeping behavior, walking, agitation. So I make them write that down so that every person that gives the medicine is required to look for that. And I'm not leaving it up to them to decide how much to monitor it or what's important. I'm holding them because they have to be my eyes and ears when I'm writing the prescription, the blah, blah, blah part. So wait 1 sec. I want to try to get a couple others. And it's 10 till, so if you need to leave, leave. And I'm not, but I'll go till 11. Go ahead.
I was wondering if this has anything to do with preliminary Alzheimer's. I participated in a study on depression with the elderly at UCSF, and I had an MRI of my brain, and I asked to have my primary get a report on it so that he could tell me in layman's language what was seen in that MRI, and all he could tell me was I was having a lot of small strokes. That's what it indicated in my brain.
Yeah.
Now, is that the beginnings of the Alzheimer's?
No, that's something different. But small strokes are little bits of hardening of the arteries, okay, what's a big stroke? It's a blood clot or a plaque that causes a clog in one of the big arteries to your brain. So if you get that, you're getting problems with speech, language, one side, the opposite side. Okay, that's what we'd call a big stroke. But we are completely fooling ourselves to think that we have vascular disease in other parts of our body, kidneys, feet, heart, angina, heart disease, and we aren't getting in our brain. It's happening in our brain exactly the way it's happening in the rest of our bodies. So the visible appreciation of that is on scans, seeing little areas of scar, so tiny blood vessels that have closed down. The problem is that when you think about the rich blood supply in the brain and how much is up there and how we just do not understand the brain, what does that little area do in you that has that little scar? It's hard to know. It's really hard to know. Maybe that is language. Maybe it's organizational ability. Maybe it's nothing because your brain has figured out how to go around that. But that's why the appreciation of vascular disease and the importance of it. If people ask me now, what is the one thing I can do to help lower my chances of Alzheimer's disease? I would say exercise. I would say everything you know about your vascular system, what's good for your heart, is good for your head. That isn't the cause of Alzheimer's disease, but if you keep a healthier vascular system, you're going to hold off the change. If like you're dialed for Alzheimer's disease, we all are at some age, you're going to hold that off for longer. So yeah, you have it. So that may be incentive for you to think long and hard about exercise, weight loss, your smoking, your packs and packs a day. Hypertension. You may want to be more aggressive about controlling hypertension or blood sugar. So one of the things I do in an evaluation, whether I'm diagnosing Alzheimer's disease or, this is only mild cognitive impairment or this is normal aging, I'm saying this is an opportunity for us to talk about what you can do so that you can stay better longer or push this off longer. So we get very serious about vascular risk factors. I always think it's important not just to say, I'm sorry, this is what you've got, but hey, these are your strengths. We need to build on those strengths, and these are some challenges, and we need to talk about driving, living alone, all the fun things. But I always try to balance out, you're really great at this, or hey, this is something you can do so that it might improve your memory, improve your circulation. So that becomes more important for you, and all that complex vascular disease stuff you need to pay attention to, all of us. Yeah?
I have a question on the role of a neurologist. My mother has non-obstructive hydrocephalus and has a shunt. And so he said we have to follow up with a neurologist and then come to me every so often.
That's the primary care provider saying that?
Neurosurgeon.
Neurosurgeon wants you to see a neurologist, okay?
He said that's important.
neurosurgeons only like to talk to neurologists. That's why they don't like to believe that anyone else exists in the universe except themselves and maybe a neurologist or two. But anyway.
I haven't been able to find a neurologist to work with us. And it's like, well, you don't need me. You just need to go to the neurosurgeon. The neurosurgeon said, what? You need... So I'm trying to figure out the appropriateness and the team of what to put together. And
does this person has dementia as part?
My mother, yes,
she has dementia. Okay. She's upstairs. It's not upstairs. She's upstairs. Okay. So what you're really talking? So she has this problem of having the spinal fluid, the cerebrospinal fluid, have this a problem where it pushed against or was there was an imbalance in how much fluid was made and pressure in her brain. So some people get that and begin to have problems with memory and balance and incontinence. And when you fix that by draining some of that, some of those other things improve. But that actually only happens a pretty rare period of time. It's still considered one of the reversible causes of dementia, but it's pretty rare that you can get all the symptoms reversed. More likely they travel a little bit together, or that the pressure has damaged her brain enough so she's showing signs of dementia. So you use a neurosurgeon because you have a piece of tubing in your head that drains into your chest usually, and you need that to function technically well. So you have to see the neurosurgeon. They're the people that put them in. After that, so that's like going to the, what would be the analogy with your car or something? You know, you need that person, the muffler guy, I don't know. But you need that person, okay? Beyond that, you should decide what's in the best interest for your mom. It doesn't need to be a neurologist. It could be a good primary care provider that's following her dementia. But there's nothing special about how she's managed in relationship to the shunt other than it's technically working, which you get from the neurosurgeon. So I would say make her care team work for you, work for where she lives, be somebody that's passionate about caring for older, person that listens to you, that allows you, very important for a family to participate, to feel like they are partners with the physician. You are put in a tough position often as a family member. You go into the office, maybe you get to go into the office with your mom. And if the person only this is tough for doctors too, if they don't care what you have to say, then that's a problem. On the other hand, you're my patient. I need to focus on my patient and not talk over my patient listening to the daughter, right? So there's a delicate balance here. So often, it depends on the situation, depends on the relationship, depends on my patient. But if I would say to families, you know, so that I can pay attention to your mom and I can tell she gets frustrated when you know, whatever, write me a note about how things are going. Leave it with the medical assistant so I get to read that before I go in the room. And I'm not going to say, well, your daughter says that you're da-da-da. I'm not going to do that. But I'm going to incorporate your information in my evaluation with her. And you really want a team, a partnership approach with that person while still really respecting your mom and her autonomy and her dignity as the patient and that interaction. So easier said than done sometimes. Difficult dance sometimes, but anybody who hasn't, I'll get you a second, anybody that hasn't asked a question that would like one? Go ahead, last one. I'm tired of hearing myself talk.
Is there a move to also educate the medical profession more about dementia?
Oh yeah.
Psychologists who really get it, but like taking her to the GI doctor or this person or people telling me scheduling
I know.
It's like, you know what? We need to think
I know.
about how doable this is.
It's very complex, and it's a very complex system with different medical records, and half of people with dementia don't have it diagnosed and written down in their medical record, which is crazy but true because it just people aren't really, well, why diagnose it if it's just, you know, nothing we can do about it? There's a lot of reasons to diagnose it. Medicines are one thing, advanced care planning is one thing. What about the person that it's not in their medical record, but they keep going to an emergency room, they keep going back because they're not taking the medicines? And in an emergency room, people, how are you doing? You gonna take this? Okay, here's the 7 pills, see you later. Well, if you don't know they have dementia, you're gonna, it's not business as usual. So we do need to educate the medical profession more and hold them accountable. So there's a couple of things happening with that. We're trying to develop a national curriculum that will, for physicians, PAs, NPs, nurses, aides, etc., a really excellent one through this national committee I'm on, and not necessarily require it, because there's not a lot in medicine you can, require, but have it disseminated really broadly. Local medical societies, state medical societies, specialties, have it available to anyone, and really encourage people to do it. We put cognitive, not screening, but detection as part of the new annual Medicare wellness visits. So for the first time, they're going to be required in a wellness visit to do a cognitive screen. So those of you over 65, you're going to begin to see a cognitive screen. Now, that doesn't mean a detection tool. That doesn't mean a diagnosis. That means a trigger. Instead of the doctor saying, so how's your memory? Oh, it's fine. That doesn't count. That doesn't count. You have to do something, and there'll be a panel of different options that physicians can use, because different educational levels, different language abilities, things like that mean we need to use different tools. So there'll be a choice for them. And however, like if I get a note from a daughter for an annual Medicare wellness visit, say, which I actually don't do many of those, but and it says, I'm really worried about my mom, her housekeeping is deteriorating, she's not cooking anymore, she's gotten lost with the car, I don't think she's taking her medications correctly. I get that note. Do I need to do a screen? No, I don't need to do a screen. That's the screen. I now need to either refer her, if I was a primary care physician, to a place that would do an evaluation, a whole evaluation that takes longer, or I need to do it myself. So yes, we're starting to try to build that in, but the more we sort of are loud about the fact that the medical system doesn't communicate well and doesn't keep this diagnosis, that providers aren't doing what we need them to do for your family member, then the more it causes them to need to do it, So I will hang out a little bit longer. If anybody, I can't imagine one more question that you have, but if you have one, I'll stay a little bit longer. But thanks for your attention. Thanks for coming to this. Thank you to AlmaVia for having us.
On behalf of ElderCare Alliance, we want to thank you dearly, Dr. Coleman, better known as Laurel.
Yes, better known as Laurel.
And thank you so much for taking out your busy day to come and spend some time with us. We hope you understand now why we are so excited to have Dr. Coleman with us for almost an entire week.
She's going to really get tired of hearing it.
I'm going to have this down pat.
I'm tired, but it's me. She has to keep hearing it.
It's good.
It's always a little different because your questions are
different. We hope as you go on with your day that you take with you just a little bit, a little piece of our passion here at ElderCare Alliance and our vision for treating each person, each aging person, with care and dignity and celebrating who they are today.